We're live, bro. It looks like we are live. I don't know how many people watching us, but watching the debate and the post-debate shows. I remember today what it's like babysitting kids. that's what I that's what I came out of it. Let me share this thing out over here. Yeah, I kind of remembered what it's like to watch two kids in the sandbox that no like play together.
Yeah.
Yeah. I was reading some comments and I saw Tyson, our friend Tyson, put down this other people from the other countries watching this and just laughing. And he's right. He's right. uh, he figured world leaders, right, watching this
Mhm.
and just watching two guys. It was something else, man. It's like really not presidential. Biden was trying. I mean, he was trying his best, but yeah, it was hilarious. But anyway, it's scary because one of those two guys is gonna be our president. I commented on one of the lives. I said, you know what we need is a third candidate. I mean, Jesus, Christmas. Come on, guys. For 1 hour and a half, can't you guys be like, just tell us what you're gonna do? Gotta. I mean, it was something else. But anyway,
Oh,
uh,
things were.
I'll be honest. I couldn't watch the whole thing. I could not watch the whole thing. I after just about an hour, I I I left the room, man. I couldn't deal with it. I was tired. It was, I'm trying to listen to people over talking to each other. The moderator cannot control them. Some guys were saying maybe you and I should have moderated the thing. I think we would have did a better job, Charlie. And
You
if
and
they don't,
you and I will
and,
probably get arrested by the Secret Service.
oh, I was thinking if Charlie was moderated, he just get up, he go there, he just slap him one time, pow, pow, behave, behave. It was
uh,
like anyway. Pretty interesting day today. Again, as far as COVID, we got Dr. Jonathan Dworkin, who'll be on tonight at 7 o'clock. And if you
yeah.
don't know him, that makes the three of us. But I did check him out. I did the background. The guy's infectious disease specialist out there in Oahu. So he's going to talk to us a little bit about what's going on in COVID and this one testing. We really spoke to a few people today about this, and it's interesting is we are all on the same page, Charlie. Everybody that I put out a post today, an open invitation for any non-government medical doctor to contact me to and endorse this one test plan. And obviously, I have yet to receive a call. Not that I expected. I was hoping to because I really do, Charlie. I want to have that dialogue with someone that can actually medically believes that this will work. I just don't think they exist, but wouldn't it be pretty cool to have somebody like that on?
Well, if you saw the four something news, KJON, followed up by the 5 o'clock news, they brought on the four county mayors. They talked about it today.
Oh darn it, I missed it.
Yeah, and Harry Kim said, you know, to, he hope he's wrong, but he still believes in keeping a quarantine if they're not going to do a second test, or they do a test upon arrival or 72 hours after. But they're electing to do a test upon arrival. If they're going to do this pre-test, right, this trans-Pacific pre-test, it would be best to get the pre-test right upon arrival. I mean, that's what everybody's. Maybe that's a question we got to ask this guy tonight. Is to get that. But um, what really kind of ticked me off is when Caldwell said that. Caldwell was of the opinion, we got to save the test because it's to test those who may have come in contact with somebody. What happened to nipping it in the bud? You know, and you know your county is the one facing the biggest problems. But, all of them said the one at greatest risk is those counties with the low numbers, Kauai, Maui, and Big Island, at the greatest risk. Well, if you know that, if we're crying out loud, that's 3 out of what, 4 counties. What happened to the majority rules? It's just like, no, it don't matter. You just like, you guys don't matter. You go with whatever plan we throw at you. And that kind of stuff, I hate to say it, Mel, but it really ticks me off to the point that my vocabulary will be like how it was in the second grade. Very few words, all of them start with F.
Mm-hmm.
So, I don't want to go there. But man, they're pushing me into that corner, boy. Tell you.
Yeah, it's I didn't see the news. I wish I did. I'll watch it tonight. But the problem with taking a test upon arrival is you will get zero screening of the passengers getting on the plane. I mean, at least with one 72 hours, we'll get some, but without a pre-flight test, then the potential of infection on that flight. The bottom line is they gotta. What is the goal here? What is the goal here? I got a call from a woman today anyway, bottom line, she had some communication with the lieutenant governor, and the issue is the economy. They're worried that the economy is going to die, and that's a valid concern. But at the end of the day, we got to make sure we're safe. We got to make sure that our people are safe, and we know how to do it. We know what needs to be done, but it goes against what the industry wants us to do.
When they say the economy going to die, okay, the economy going to die if we don't do anything, if we don't do nothing, right? If we just sit back. That's not what we're saying. We're saying is, hey, open up, but let's do it safe, okay? We're not saying completely shut down. There are the ones that went shut them down. Wasn't the people. We never shut this thing down from day one.
Mm-hmm.
They had knee-jerk reactions. They went shut down everything. We never tell them shut down. They could have been, a lot of businesses could have been open. They weren't even affected, right?
Yep.
So that's why I always said, if you have an effective business that you garner a lot of traffic, you're going to get penalized because why? When you get plenty of people, they think you're going to spread the virus. There is not one medical data that can show your business or even the contact tracing. That's why I said contact tracing got to be paramount. Because you would go to the contact tracing data report and says, okay, let us look at Windward, Oahu, right? All those business closed down. And let's point to any businesses. Hey, was there ever a infection started from this business? Zero. So, and maybe I'm looking at it too much common sense because, we always said that for some reason this year, common sense, and flush down the toilet someplace and no can get them back. You know what I mean? I don't know.
Yeah. Well, we got some rough times coming up. I had a chance to talk to Dr. Dewolf Miller today. Some of you may recognize the name. He's the guy, kind of older fellow with the beard. Looks like
Ben Casey.
Like a scientist. And he is. He's a epidemiologist. He's emeritus professor at the medical health school, or whatever it's called. Is it the Johnny Burns Medical School at the UH? He's retired now, but that's what this guy does. That's what he's done for his whole life, and he's been all over the world. Last year, he spent most of his time in Egypt, but they've worked on. That's what they do, and he'll be on our show on Saturday night. That's going to be powerful. I had a chance to chat with him today a little bit, and this guy is going to be incredible. He's so smart. It's like fascinating. You know how it is, Charlie, when you kind of like when I talk to you, I just get fascinated, But that's how this guy was like, wow. I mean, and he'll talk about he'll talk about he'll talk about the science. He'll talk about how the health department should. Anyway, I'm not gonna steal
You
his
know why I'm
thunder.
laughing, right? You know why I'm laughing, right?
Why?
I'm laughing because I even fascinate myself too. That's why.
You know, um, I wish, I wish, Charlie. If as it, I get plenty of wishes, but if I had one wish as it relates to what we're doing right now, and I see a lot of people posting this, is how can we get this message? How can we get all of these experts in the same room with these decision makers? Uh, because I don't know, man. I look at it like kind of a waste. All of this knowledge and this information and this doctors and scientists and these people that are just willing to help and they have the information.
Well, you want to be fascinated with my answer? You want my fascinating answer? The way to do it is one day when we know got all the brilliant minds up there on the fifth floor at the Capitol, we get all these fascinating experts together. We dress them in the Mel and Charlie fumigating service. We send them up there under the disguise of fumigators. They're gonna let them in, and then when they go in, they're gonna make like they're fumigating, and right then and there, they're going into Operation Niele. Operation Niele is when they're gonna listen to what these guys talk about, and they're gonna
Yeah.
start bombarding them with their. That's the only way
So
you
we
can
gotta
do it.
lock the doors. We gotta
Yeah,
secure the doors so they cannot leave.
yeah.
Because it's this information is so real. It's it's accepted by the experts all over the world. And then here we are, little Hawaii.
Yeah.
No, we're gonna do them our way. We're gonna do them our way. And I think that's where we keep finding these guys, these experts, and I'm thinking, wow, what a waste. And a lot of them have spoken to decision makers, whether formally or not.
Yeah.
But the message is not getting heard, and that's what's driving me nuts. And
You,
you
you
know, I
know,
I I just don't want. I fear. I'm afraid of what the outcome of this will be. I really am. Because everybody knows the shortage of hospital resources. One big surge, and that's all it's going to take. It's not like we don't have the luxury like all these other states that can transfer patients to neighboring counties or cities or states.
well, this
We
is
don't
this
have.
is what's gonna happen. This is what's gonna happen. Right now, I am so confident that if we were to get experts in front of them, whatever they say or do, it will not hurt this state at all because we cannot get any worse than where it is right now. And that's a good place to be. Right now, they're at the bottom of the barrel. Unless you get on hold and go beyond that bottom of the barrel, you can't do no wrong. You can only go up from there. And that's something that I wish they would look at. I mean, if you want to go down in history, the governor will make his final speech on the final day, right? It's been a great 8 years as governor. Oh, shut up! Give me a break. Enough already.
Well, if he makes it to the 8 years, I highly doubt that this legislature would impeach him. But when things go sideways, or if things go sideways, then that's going to be the legislature's. He'll become the scapegoat. He'll become the scapegoat, and they're going to put all the blame on Ige and impeach him. But that's not the case, you see, because it's this whole process of democracy. You get the administrative branch, the legislative branch. The legislative branch got to get involved. We got to start hearing from them. And I understand the back door, back whatever. I understand that, but you guys got to tell us what's going on. I mean, we're hearing it from our sources, but the general public's not hearing it, and they need to start. Somebody. I mean, right now we're rallying people. The people leading the charge should be our legislators. They should be the ones, and
They're not
we
going
rally
to stir
behind
the
the legislators. Huh?
they're not going to stir the apple cart because this
Yeah.
is an election year, and everybody
Uh,
playing it safe. And this is the wrong time to play it safe because It's okay to play it safe if you don't have a pandemic looming. It's
Hmm.
okay to play it safe if people are not going to die. But when you play it safe and you have those variables inside, you err on the side of. It's just like me who teach CPR. I said, hey, if you're afraid to blow into the person or give multiple resuscitation, don't. But at least you can give compressions. Better than nothing, right? So these people, then these our legislators, because we don't hear a peep from them, it seems like they're probably gonna take the credit after. Oh well, who was working really hard behind the scenes, and la 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 la.
Well,
Okay.
what are they gonna blame? Well, if it goes sideways, they're gonna, then they're gonna blame. And trust me, I mean, ultimately, yes, it's the governor. Ultimately, it's the governor. But we get a hell of a lot more legislators than governors that should be putting the pressure.
Yep.
Should be putting. We saw it a Senate committee meeting, a COVID committee meeting. We saw that for a while.
Yep.
But they couldn't get rid of anybody. It was a whistleblower that got that done. It was a whistleblower that started the not the legislature, and they need to start taking an active role. And again, a lot of these guys, my friends, they're gonna be pissed off. But like Dr. O'Carroll said, now is not the time to be worried about hurting people's feelings. Yeah, hey, personally, guys, I'm all good, man. Professionally, do your job. That's all I'm saying. And if you guys cannot apply the pressure to this government, if you guys can all sit back in your offices in that square building and 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 cannot come out publicly and tell this governor that what he's doing is wrong, then as far as I'm concerned, you're part of the problem. You're condoning that behavior. You're allowing that behavior. You guys are the voice. Yeah, you guys are the voice. I mean, if we got an open invitation, guys, come on our show. Any one of you. I stopped sending invitations because it got ignored. Early on, yeah, they all wanted to come on our show. Now they don't like them on the show. But it's open. Invitation is open, people. Anytime, anyone, I don't care what side you're on, you come on the show and share with us what you guys are doing. Share with us what you guys are doing. Because right now, all we hear is from Lieutenant Governor Josh Green and from Avi Manis from Hawaiian Airlines. Every so often we'll hear a little peep from Governor Ige, and then of course Caldwell. That's all. There's nobody else. Everybody else is hush hush, hide behind the wall. Just wait till this passes because it will pass. Well, it will pass, but it's going to leave a wake of this devastation and destruction, and somebody should be concerned about it. So, absolutely, I'm sorry for going down that road, but we got to get some activity from our representatives and our senators. I mean, and trust me, we know Senate President Kochi works hard. We know Senator Jared Kyoho Kalole working hard. I mean, all behind this. But let us know, guys. What's so, when you guys build one gym or when you guys go do, boom, press conference, right? Press release, do the same thing. Have a joint. Have the Speaker of the House, Senate President come out on the lawn in their nice podium with the big seal and come up and say, hey, this is what we're doing, people. We disagree with this. And we need your help to get the message to or come out and say, we support the deal. We support. But if you do that, you will not get elected in the next election. You know that. So, right, the best thing for do, ride the pine, shh, and just let the crap go. That still might cost you the next election. So anyway, we got Dr. Dworkin here. Any comments on that, Charlie? I'm sorry, man. I got pissed off a little bit.
No, I just thought that you had me on mute there for a while.
I never have you on mute, bro. I not touch your mute. Fasten your seatbelts, ladies and gentlemen. Fasten your seatbelts. Fasten your seatbelts because I think the car might not be moving. Where the heck did he go? Uh-oh. Uh-oh. He was there.
Yeah.
Hmm.
Well, while we're trying to while we are trying to look for him, just know one thing: we got all these special COVID committees, and you know it's good to have committees if they work for a common good, but it's not good to have a committee where all title, right? All title
They are,
and
you
lost
know,
power behind the committee. So
there's some type of leaders, and I've seen so many of them that they have a meeting to schedule the next meeting, to keep the calendar full, so they can, at least when they go home, they can convince themselves that they're doing something, rather than have one meeting, establish what's going to be done, uh, putting people accountable to a task,
yeah,
and then following up on the tasks. That's leadership, not just have a meeting to have another meeting to have another meeting, and then come back. And that's, how you don't think this is one of the most common answers you get from anybody in the state? Oh yeah, we're having meetings once a week. Oh, we meet regularly. Oh yeah, we're meeting. Oh yeah, we're meeting. What the hell is the outcome of the meeting, people? There he is. I better get him in right now before he changes his mind. Okay, fasten your seatbelt, people. Oh, he's on. There he is. There he is. All right. Gosh, did I put the right picture on the Facebook post? I don't know if that looks like the same picture I put on the.
oh, this guy looks. He looks like a.
Are
He
you
looks like.
Jonathan Dworkin? Are you Dr. Jonathan Dworkin?
I'm, I'm that guy.
Okay.
Nice to meet you guys.
Right on, man. I'm Mel. The Hawaiian is Charlie. Thank you for joining us tonight. We heard a lot of good things about you, man. There's a lot of people watching because they said you're explosive.
I hope I don't combust.
Spontaneous combustion, huh? Yeah.
Thank you very much, Doc. A pleasure to have you on, and I'm sure you know we do this every night. We bring on all kinds of people, and all experts, not all, because sometimes we bring on politicians too, but most of the time we bring on experts. And someone recommended that you come on. You're an infectious disease specialist. So the first question is, why would anybody want to do that? I don't know. It's like being a dentist. But we appreciate you on the show. Why don't you introduce yourself? Tell us what you do. What the heck does an infectious disease specialist do? And then take us on a little journey on how COVID, pre-COVID and now. What's Dr. Dworkin working on?
All right, thanks. I think some of our mutual friends must have thought I haven't stepped in it enough recently, and they wanted to give me a chance to do it with you guys. So infectious disease, it wasn't supposed to be this exciting. It was a field that 30, 40 years ago, a lot of doctors didn't want to go into because there were so many exciting things going on with heart medicine, oncology. One of my favorite ID docs is this old guy, Dennis Mackey, who teaches over at Wisconsin. And he does a lecture, and it's kind of funny. It starts with him talking about how everybody tried to talk him out of going into infectious disease because it was a dead field. This was back in like the 70s, And if you think about it, they had pasteurization, they had vaccination, we had clean water, good sewage, antibiotics. There was considered not much to do, right? And then he brings up this little slide, and he shows all the infections that have been discovered since he got that advice, right? And HIV, hepatitis C, one after another. And not only is there a long list of them, but here's the really creepy thing: over time, they're more frequently being discovered. So it seems like there's an acceleration in the rate of new infections that are being discovered. Now, is that just because we've gotten better at finding stuff? Well, a little bit. But I think it's also because our relationship with the environment is changing. And as we push more into it and we disrupt it, we upset it and things come back at us. And that's kind of what gets us to COVID, right?
Hey, Doc, real quick.
Yeah.
Where are you? Are you in the Big Island?
That's right. Yeah, I'm on the Big Island. You guys are on Kauai, right?
Yeah, and I
Opposite
thought
ends.
for some reason I thought you were on Oahu, and I hear a Koki frogs.
Yes, I hope the sound quality is okay. Those are the
It's
cookie
perfect.
frogs.
It's perfect. But I didn't mean to interrupt, but we got to let everybody know to share. Charlie, we get this high-tech graphics program in our thing. So we just want everybody to share this because I have a feeling it's going to be fun. I just can tell. I can just tell. But anyway, sorry to interrupt, Doc. So you practice is in on the Big Island.
Yeah, I was at Queen's Punch Bowl for about 10 years on Honolulu. Yeah. And then I started coming over here a couple of years ago, Waimea. Like it so much. People here are beautiful. It's friendly. I like being in the country. Kind of always wanted to be in the country. And, you know, in the last 6 months, it got harder and harder to go back and forth. For one thing, it just felt kind of sketchy. But it also, you know, there were all these hoops I had to jump through. And it was hard to have patience in both places. So, you know, my wife is a teacher. She was home for months. My kids were out of school. We thought, okay, we got to be one place or another. So we chose to come over here. And now I'm at Waimea.
Perfect. All right.
So,
well,
so that's me.
So awesome. So now we're here at COVID. We're about 7 months in. A lot of things happening. A lot of things happening. What's your assessment, man? What's your take? What's your take on COVID? And we know how it's impacting everybody on all the islands across the world, really, but especially for Hawaii, mainly Honolulu. But oh no, I'm sorry, you guys got some stuff going on the Big Island as well. What's the biggest issues you see going on with COVID right now, besides the one test system, which we'll talk in a little bit?
I think the main thing is just how much it disrupted and distorted our lives, you know? So if you look at Queen's Punch Bowl, where I worked, you know, we were all in practice, seeing patients, doing our normal thing. And, you know, we saw it coming a few weeks before it hit us. Some of us saw it a little sooner than others. There was a lot of denial at the beginning, as I'm sure you guys remember. But when it hit, it totally disrupted everything that we do. And me personally, the worst part was like right before it hit. It's that feeling you have like when you know you're about to get in a fight and you know, but you're not there yet, right? And it was coming at us. We couldn't test anybody. You know, I was walking around with a 3x5 card in my pocket with a list of every symptom that I had read in every article that could be COVID. And every single patient I ran into, I was scoring them in my head as likely, not likely, whatever, to figure out whether to put them in their own room. We couldn't test anybody. We couldn't figure out if they had it or not yet. I just wanted to make sure I wasn't responsible for a cluster blowing up in the hospital, you know? So that was the kind of state we were in. Once the testing came online a little bit, we had a better idea of what we were dealing with. And the situation kind of clarified. And we saw, okay, there is disease, but this is how much disease there is. And it wasn't long before we could get testing done on pretty much everybody we wanted who was coming into hospital. Now, despite that, hospitals have still had problems. Interesting. And that gets at that one testing that we'll probably talk about. There's no foolproof way to keep it out. It's a sneaky bug. And, you know, and to try to find it when you can't even test people, that like the situation we were in back in March, I felt like I was in a boxing match and my eyes were closed, you know? And when the testing came online, suddenly my eyes were open. And that felt a lot better. Then I was like, okay, I can get through the next few weeks of my life now. But that was sort of how it began. Pretty quickly, it began to fill up units in the hospital. And back in April, and this is where I think a lot of people compare it to flu because it's a respiratory virus, flu to respiratory virus. I understand that. I do that myself sometimes. But it's not like flu because I've never seen flu fill up a unit of the hospital in 3 days. You know, I've done ID for 10 years. We always have bad flu in the winter. We'll get a few really sick people in the ICU that test positive for flu, you know, and maybe we'll have a death. Count on one hand the number of patients I've had die of flu in the last 10 years, you know. But this thing will fill up a unit in days, and then it'll fill up the next unit, and then it'll fill up the next unit, and then it'll fill up the next unit. And I've never seen flu do that. So the question is, does it do that because it's so much worse than flu, because it kills so much more efficiently than flu? Or is it just that what we're seeing is the tip of a very big iceberg. And we've got this enormous epidemic that's racing through that's largely invisible. But because it's so large, we're seeing just the tip of it. And that's what we're experiencing in the hospital. And it turns out it's a little bit of both. We think that it is worse than flu, probably 5 times worse than flu. In terms of the number of people it kills, maybe 10 times worse. It depends on which study you read, whose statistics you believe on that. But what we're also seeing is that there's an enormous epidemic that we're not even detecting. When we check people for antibodies, we find that 10 times more people have antibodies than we actually diagnose with this swab. And what that suggests is that there's a really big, fast-moving epidemic that's largely invisible for whatever reasons. And that's part of the reason why you can fill up a unit of the hospital so fast. And it's hard to wrap your head around this stuff. It took me a while to wrap my head around it. You know, I was like, what am I dealing with here? Am I dealing with something that's like a world-ending bug that's going to kill at a super high rate? Or is this a wimpy thing that's just really big? So that's stuff we're still working out.
Now, let me ask you something, Doc. You know, because my brother died from it. He was one of the first, within the first 3,000 in New York that died.
Oh, my God.
And I remember, you know, I was telling Mel that I was fortunate enough, after I retired from the police department on Maui, I worked for the ME's office in Honolulu. So I had the, you know, ability just to know enough, you know, when you're dealing with certain things. And one of the things, you know, getting the reports from the New York hospital where he passed away from, is they try to dialyze him in the early stages. But right from the get-go, the doc said, you know, we don't know what it is, but we're putting him on a 24-hour dialysis. I go, should I say it? I mean, I've never heard of 24-hour dialysis. So I had to go along with it. And then they said, you know, for some reason, your brother's blood is just gunking up the equipment. Did you ever see coagulation happen so quickly in someone with the flu?
Yeah, I mean, that's one of the features of this disease that makes it a little bit different. Mm-hmm. I'm thinking about what you're saying, and truthfully, you can see clotting with the flu. We know, for example, that if people have really bad flu, they're more likely to have heart attacks and whatnot. And we know that that's one of the reasons why we think the flu shot is good. You know, it's not just preventing the flu, it's preventing those complications of the flu. But this seems to be at a different level. And there's a subset of patients who, you know, develop a vascular injury, a kind of blood flow injury. And in those early days, we didn't really have a real good sense of that. You know, we were thinking we're treating some sort of viral pneumonia. Our motto is kind of simple. It's a virus. It's going to cause pneumonia. And then all these reports start coming out of blood clots and, you know, people having clots in their lungs, clots in their coronary arteries, strokes, things like that. Now it's very common to put these people on anticoagulation. One of the many things that's changed in the last few months. And I think we've gotten a little bit better at recognizing some of these complications. When I was on service at the very beginning in March and April, I mean, we had nothing. I mean, first of all, we couldn't diagnose it. Then we could diagnose it a little bit, right? And then we didn't really have any antiviral medicine. You know, we had hydroxychloroquine in a clinical trial, and you guys have probably gone over that. So that was it. You know, you got hydroxychloroquine or you got placebo, and you got, you know, tender loving care and my smiling face and some oxygen and, you know, and that kind of thing. In July, when we got our second wave and I was back on service, you know, we had antiviral medicine, this drug remdesivir that's now available. We were giving people convalescent plasma, which is still controversial. But talk about old school medicine. I mean, you're taking the antibodies from somebody who's recovered and you're giving it to people who are serum therapy. It's like from 1910. That's how old that stuff is. It's pre-antibiotic era. But, you know, there's good theory behind it. So we were using that along with the antiviral. We were anticoagulating people. I was very clued into, you know, are they having any chest pain? Are they having any more shortness of breath today? I'm looking for clots every time I'm examining them. And if there's any hint of it, we're starting them on an anticoagulation medicine. We had steroids based on this big trial that came out of the United Kingdom that showed mortality benefit. We understood that the inflammation was driving a lot of those complications. So the patients seem to be doing better. during the second wave. So that first 3 months, I think a lot of people don't understand this. That first 3 months we bought did get us something. It's not like that was useless time. I mean, we didn't get our public health infrastructure up as well as we should have. But the medical science advanced enormously in those 3 months. It'll probably advance enormously in the next 3 months. So you don't want to be like, it stinks to be someone who's like one of the first people to get a disease. If you can delay it, you're likely to get better care.
Yeah, because his, I took everyone on a journey because his started like the week prior, like from a Sunday to a Monday. And by Saturday, he passed away 1 week later. It was just super fast. And everything that came out of that report that I was reading was just like something out of a sci-fi. You just don't hear it. He went on hydroxychloroquine too, and they had to discontinue at one point in the middle of the treatment because it was doing some funky things to his heart. That whole issue. So now they were just trying to make him feel comfortable, and like you said, buying time and trying to redirect. How can, what can we do from this point? And they tried. I hold nobody at nobody's fault. They tried because, like you said, it was relatively new. He was probably one of the first 3,000 in that group, and it was just a nightmare for the family. You get to talk to your loved one, and I think now more so knowing that this thing is like the big boogeyman, right? We hear a lot of things that when people are dying because you can't go and be with them, it's even more painful when they have to die alone. That's the other side to the whole equation there. So
yeah, I hear you. And that was one of the hard parts about being a doctor too, is we had a ward full of people that nobody could visit, and when the PPE was short, it was even hard for us to get in and out of the room. It was like a whole process and procedure. It's gotten a little bit better. But it is a very lonely place to be in one of those COVID unit rooms. People get delirious, and going in there, every time you go in there, it's an infection control risk. So you got to be strategic about when you go in and out. You want to take care of the person, and the nurses. I mean, they're like total heroes. I mean, as far as I'm concerned, I go on the unit. I joke around with them for a few minutes. I put on my stuff. I go in, I do an exam. I try to say something nice to the patient. I think about what I can do to make the situation better. I write my note, and then I'm on to the next thing. They're there all day, those nurses. They're breathing that air. They're in and out of the rooms over and over and over again. And it's not a surprise to me that they have this, a fairly high risk of getting infected doing that, even if they do everything right. So I always think to myself, what about those people? Those are our frontline guys, really.
Yep.
Girls mostly. But and are we doing them the right thing with these state policies that we're setting up now? So that's what I come back to.
Well, I mean, one of the like Charlie's brother and all those that went on and got the virus early and basically provided the research, and a lot of them passed away. And but if not for them, and doctors sharing information and learning what this virus. I remember early on, and no one knew what the heck was going on. No one. And talked to doctors, and it had to have been a nightmare for you guys. And then of course the nurses. Geez. So yeah, and that's why, Doc. So we Charlie took us on this journey, and there were days in that very short week, the days that the brother was doing better. Charlie was all happy in the morning, calling me up to tell me how the good news that he had received, and then the very next day was completely the opposite, and then it didn't go well. So that's kind of why we do this show every night. And at that point, it was just kind of we didn't have policy issues with the state. They were still trying to figure out what the heck they were going to do. But it's been 7 months now. We've had more than enough time, I think, to formulate policy that is in the best interest of the people. You bring up a good point about the nurses, because I think they forget about those people, the frontline soldiers that are being exposed to this on a daily basis. I have a lot of friends that are nurses I have a couple that are on Oahu that confide in me about what's going on over there, and they are it's frustrating. So as we move towards this opening on October 15th, and we've seen the issues with the testing. You know, early on, like you said, you couldn't get a test. I don't know how it was on a Big Island, but on Kauai, somebody joked to me once. He said, "Mel, if you show up to the test tent with your lungs in your hand, they might give you a test. But if you didn't have all the symptoms, you don't get a test." And then, so you had that whole issue with the testing. You couldn't get testing, and then the lockdowns, and then it was just impact after impact after impact. And now we looking at opening up interstate travel or trans-Pacific travel. And I have no idea what you're going to say, but we have spoken to so many doctors and experts about this testing, that testing and contact tracing is so critical. Two parts I think that we failed in this state from the beginning, and maybe they're turning it around now with the new director. But what is your concerns going forward now? So we protect our people and our doctors and nurses as well.
Yeah, I mean, there's a lot of moving parts. I admit my bias. I'm an ID guy. I want to control the infection. To me, that's what winning looks like. I don't want us to become, Russia or some other place that has out of control transmission and people are dying in massive numbers. What happened in New York, I don't want that to happen here. New York is kind of a unique situation because a lot of people were going there from around the world. So it was the first place that got hit. And they had the same testing problems where they couldn't see what they were doing, but they had a much bigger wave crash on them. And interestingly, I remember reading an article maybe a week or two before New York blew up. They had a disease monitoring network. It was called, it was the Influenza Monitoring Network. They call it ILI, influenza-like illness, where they monitor people for respiratory symptoms. And they report it. So it's just a syndromic thing. It's not based on testing. It's based on how many people are complaining of symptoms, right? That spiked right before the big wave hit. And we all kind of saw it coming, and it was a little bit like watching like a slow motion car crash, where you knew it was about to blow up right before it did. And when it did, it was everywhere. The situation was compounded by their nursing homes getting infected. And if you look at the neighborhoods in New York that got hit hardest, one of them is a place that I trained in called Elmhurst. When I was a medical student, I did rotations at Elmhurst Hospital in a neighborhood called, in a part of Queens called Elmhurst. It's the most diverse couple of square miles of the United States. And it's a lot of new immigrants, and they come from all over the world. The welcome sign in the hospital is like in 100 different languages. And the most common country right in that immediate neighborhood is Ecuador. So I remember that neighborhood because I used to go eat Ecuadorian food in the neighborhood during lunchtime. And then I go back and round. That place, everybody there is working class. Everybody there is using public transit to get to their jobs. Nobody there gets a lot of time off or paid time off or anything like that. It's a working neighborhood. And they got crushed. They got crushed because they were all on top of each other, using the same public transit in the same crowded buildings, unable to take time off from work. And it just exploded, right? We're in a different situation. We fortunately, we've got this blessed ocean between us and the rest of the world, which means we can actually do border security in a way that other places can't. And border security, I don't mean it in the Trumpian build a wall way. I mean it in the pandemic build a wall way. We can control our border in regards to this pandemic, and there are some islands that have done that very effectively. New Zealand is probably the most prominent example that everybody likes to talk about. But there are other ones as well. There's not a big epidemic going on in many South Pacific islands. There's no COVID at all because they just set up very, very, very stringent quarantine early on. And they've just been able to keep it out completely. Now, that said, we're a tourism economy, right? And I have to understand my own biases. I'm an ID guy. I want to control the infection. I understand that there's other things that are important. And the question comes down to, if you lower our border security and you allow the epidemic to surge, are you going to get the benefit that you think you're going to get from that? And are there going to be other costs that you're not considering? I've not seen any great evidence that the economy does well in places that have uncontrolled transmission. I just haven't seen it, and I've kept my eyes open for it. I'm not an economist, but I talk to economists. I talked to Sumner LaCroix, who's one of the UH guys who was on the UHERO report back in June. They're not fond of uncontrolled transmission. And I don't mean to speak for Sumner. He can give his own thoughts. Sometimes you guys have the words plan. But economists around the country have weighed in on this. Most of them want to see at least good virus control as a prerequisite to opening up the economy. So I don't think these things are really at odds. And there's certainly going to be gray areas. There's lots of gray areas. So I don't know. I'll just stop there. Do you guys want to take it in any particular direction?
Yeah. Let me ask you this question that's been haunting me, I guess, for a while.
Yeah.
If there's this mindset that the administration has that one test is the fix-all, and I don't know. We asked the $1 million question last night. Is there any doctor right now willing to sign off on the one test? And the doctor we had on last night said, you'd be hard pressed to find one to do that. So I guess, is there something that you can see why they have this structure that they firmly believe that, even, we talked way back when, we didn't know too much about asymptomatic. I didn't know about it. But then it started to be the big boogeyman, and the percentages were high that people will be carriers and you won't know about it. Okay, so you throw that into the mix. They got this big thought process and they're convinced this is the way to go. Do you see something in it that maybe the lay people out don't see?
Well, I've seen it fail. Okay. So I think that's what I've seen, like in real life, not in theory. We've had patients at Queens who their relative was on the mainland, got tested before hopping back on a flight, comes home with a negative test, then develops symptoms, infects the family member. The family member ends up in the hospital. This has already happened, and we haven't even opened the plan yet. And what I alluded to earlier, there's a lot of testing going on to try to create bubbles in different places. And it's not foolproof. You'll still see transmission after single tests in some of those bubbles, including sometimes in healthcare setting, right? So the question is why? What's going on there? Why doesn't it work? Back in June, the UHERO guys, Sumner, Tim Brown, Dewolf Miller, they produced a report on opening up tourism, which I was really into. And it talked about one test. And it ended up becoming the basis of like a whole petition that a lot of the healthcare people signed, arguing for a test before people come here. You have to understand the alternative at that point was open up with zero tests. That's what people were talking about, right? So we thought a test was a lot better than no test. And I still think a test is a lot better than no test. But I don't think we had full information yet on the biology of the virus. And what we now understand is that people get exposed to the virus. So they're infected. They get exposed to an infectious dose on their eye, they breathe it in, whatever it is. And then they develop symptoms, if they're going to develop symptoms, on average 5 to 6 days later. And here's another important point, it's variable. Some people will develop symptoms really soon after that. Other people won't develop symptoms for a while. It's not like it's fixed, right? And it probably has to do with how much virus got on them and where they got inoculated, maybe something with their immune system. So there's some variability, right? And we think that people start shedding virus, they become infectious to other people a couple of days before they start developing symptoms, if they're going to develop symptoms, right? We don't know exactly how that works because we can't do experiments in people where we experimentally infect them and then watch to see when, and then swab them and wait to see how long it takes them to develop viral shedding. That would be totally unethical. So a lot of this stuff is put together by, actually, who put it together were these really awesome public health systems in Asia. Places like Singapore or South Korea where they really have excellent public health services. They do very detailed investigations of cases. And they say, okay, we know that this person got exposed to this other person on this day. And we know that their wife got infected on this day. And they can put that together with dozens of cases. And then they can reconstruct timeline, right? So that's where most of this stuff comes from. And what we realize is people are getting infectious a couple of days before they're actually developing symptoms. And that's a really common way that the thing spreads, right? The other thing we think going on is that it sometimes takes a couple of days before they start shedding after they get that infectious. And so you get exposed and you're going to be like, you're kind of like a Wile E. Coyote out over the edge of the cliff before gravity takes effect, right? You've got that interval where you're kind of hanging there. And in 24, 48, 72 hours, you're going to start feeling it. But you're not yet shedding the virus, right? So if we test you during that first 24 hours or that first 48 hours, there's just nothing to pick up. It's not that the test is bad. If the virus is there, if it's a good PCR test, it'll detect it. But if it's not there, it's not there. The other thing is if you test somebody 72 hours before they get on the plane, that leaves 72 hours for them to go be a knucklehead and get themselves infected before getting on the plane, right? So you're missing all of those people too. And that's why these things don't work. You need a couple of time points for it to be effective, right?
No, based on what you're saying, and it goes in line with what many others have said as well. I'm just wondering why the lieutenant governor is so adamant that what you just said about getting infected within 72 hours of flight, his belief is, nah, it won't happen. And I don't know why. And that's the thing that baffles many of us.
Well, I mean, there's a cynical explanation, of course, which I'm sure it's coming to everybody's mind. But I always think the best way to argue with people is to state the best version of their argument. And I think the best version of that argument is something like this. We are an economy that may be entering a terminal downward spiral if we don't get people back to work. This is what he would say. I don't know what he would say, but this is my thought on what they might be thinking. And maybe it's true. Maybe we need to acknowledge that there might be some truth to this. If the federal money runs out, if we don't have things open, we go down. And maybe we need to open things up and allow transmission to happen, because that's the only way we're going to have bread on the table and a roof over our heads. If that's the case, though, that's what they should be saying, right? They shouldn't be saying, don't worry about it, it's going to be fine. This is an 80% effective test. That's what I object to. I object to the sort of the medical and the scientific BS. I think you can make a case for allowing tourism. One of our good colleagues, Tim Brown, ran some numbers recently on this, and what he did, you guys might be interested in this, he looked at the states that send us tourists in 2019, and he assumed 8,000 visitors a day, because that was a number that had been thrown out recently. And then he weighted it by the states that had sent us tourists, that it would be proportional, right? And then he went on and he looked at their infection rates. And he figured out what the approximate infection rate is. And it's variable. Some of those states are pretty low right now, probably well under 1%. Some of those states are getting their butts kicked, and they're probably over 1% infected at any given time, right? And then he plugged that into the numbers. And then he assumed that the one test would be about 2/3 effective, which is maybe a little optimistic, but we were trying to be nice to the other side, right? And the number we got was 30 to 40 people a day coming in undetected with COVID. So then the question is, can we handle that? Do we have a public health infrastructure in place that can handle that 30 to 40 a day? How many can they handle a day on Oahu? I'll tell you something. 2 months ago, the number was, I think it's probably a little bit better now. They're reforming. They're trying to do a lot of things to get their act together. But, an extra 30 to 40 is going to stress them. They're already stressed. They're close to 100 a day. And I don't think they're able to do that right now. So you add another 30 to 40. Neighboring islands, how many are they going to be able to handle? Because some percentage of them are going to go to the neighboring islands, right? We don't have a lot of ICU capacity here on the Big Island. I'm worried about that. Somebody comes in really sick here. We've got non-ICU doctors doing ICU things and call in ICU doctors on the telephone for help. And that's the reality, right? So we have to think about all that. And I think we also have to think carefully, if that happens, what's it going to do to the rest of the economy? What's it going to do to the other 2/3 of the economy? Not tourism. And what about school? That's the thing. If you talk to a lot of economists, tell you school is really important for the economy. Well, school's also really important for healthcare. So that's something that we agree on. And a lot of people want to see schools open first. If you're going to do something that's potentially risky, get the kids back in school. It's going to be super high yield for so many reasons, right? So I think if they're going to make the economic argument, they should answer those other questions, and then see where it shakes out. But what I object to is the sort of pretend safety thing.
Well, go ahead, Mel. Go ahead, Mel.
Oh, no, go, continue.
Well, Mel and I have always said this to all our guests. We all believe that we're not saying to keep the economy shut down. We're saying open it up, but just be safe about it. Because we believe it can go tandem, having that safety built in and leaving the economy open. But to not even look at the safety tandem and just look at the economy alone, that's where the argument comes at. They purport the argument to be, well, we have to open up our economy. We're not saying that. We're saying we agree. We're just saying do it safely, right? It's like you learn how to ride your bike, you use the training wheels first. If not, what are you going to do? And, being on Oahu before, just imagine you put your kid on a bike, no training wheels, send them down Wilhelmina Rise. Guess what's going to happen way at the bottom of the hill? Yeah. The kid probably will hit a telephone pole on the way down. That's not what we're saying. We're saying put in that safety valve, and then, we can all, coexist, I believe, if it's done right.
And if you do that, you maybe have to accept that things go a little bit slower, right? So you're not going to get the 8,000 a day right away. You're going to do 1,000. You're going to prove you could do that, and then 2,000. That's the trade-off, is you got to go a little slower. I don't think they want to go a little slower, But the other side of this is infrastructure, right? So this is not going to be our last infection. The things that were happening that caused this disease to emerge are going to continue to happen. So we had SARS, we had MERS, now we have this one. This one was the one that went pandemic. There were 2 other coronaviruses that were pretty scary before this one that didn't go pandemic. We'll have another respiratory virus at some point down the road, either a coronavirus or a flu virus. It may not be that long. It may not be 100 years before the next one. It may be 20 years, 10 years. We don't know because of the way the environment's changing, right? So anything that we put in place now is going to be the system that we're going to be relying on next time. So do we want a system that is kind of slapdash and decided by a few business guys in a conference room somewhere without any input from epidemiologists and scientists and educators? Or do we want an infrastructure, a real infrastructure that we can then rely on next time? And the infrastructure includes things like developing our own testing capacity in these islands. One of the things that the Koreans did so well early on was they had companies, they had entrepreneurs there, and the government encouraged those companies, and they were patriotic, and they rose to the occasion. When the whole rest of the system froze up, they were producing tests for that country. And then they ended up having an excess of tests, and they ended up exporting it to other countries that didn't have their act together as well, right? We have companies in Hawaii that want to do that for us. And if we help them, those could be places that our kids work in 20 or 30 years, Same thing with the software, right? There are a bunch of people who have tried to develop apps to help with isolation, contact tracing, quarantine, all this kind of stuff. That's a software industry. It'd be nice to have a software industry. It'd be real cool, So, but we got to support these things. If we believe in this, we got to support it, and we got to make that our model. And that means doing things a little bit thoughtfully,
Well, I think the pretend safety, I agree with you 100%. I mean, if it is in fact the economy that, they've succumbed to the pressure of corporate America, of Hawaiian Airlines and United and all these airlines and hotels, then say it, because what their theory is making no sense, especially when some of these people have completely did a 180-degree turn from where they were 3 months ago, 2 months ago. By the way, do you know Dr. Wignall from Jakarta?
No, I'm not familiar.
That was just a question. That was just a question on the comment. How about Dr. Dewolf Miller?
Yeah, yeah. I know Dewolf Miller.
Yeah, Dewolf Miller. I spoke to him today. He's actually supposed to be on our show on Saturday. He just texted me about 5 minutes ago that he's got to reschedule, but so we'll have him on next week. But how about Dr. Jerome Kim?
Jerome Kim? No, I don't know.
He's the Director General of the International Vaccine Institute in South Korea.
Okay.
He'll be on our show tomorrow night, so make sure you tune
interesting.
in.
All right.
Yeah. But I guess for me the question is, so they're proposing a one test, whatever they're proposing. What options, if you, I know, because there's been several papers out. I know the Quiet Discussion Group was one of them. I know Dr. Dewolf Miller was telling me about the early stages and with Sumner and was it Brown?
Mm-hmm.
But anyway, if you, as the infectious disease specialist, what would you suggest? What would be your to keep Hawaii as safe as possible by keeping up that border wall, that infectious border?
I mean, one thing we have to acknowledge with the science and also with tourism is, as I mentioned before, we don't know precisely what that time interval is from the time that somebody gets infected to when they start shedding virus. So there's some legitimate disagreement on that. And that has implications for the value of one test. I go back to the real world, which is that I've seen this thing fail in the real world. And that's all I need, as a clinician. So that's one issue. The other issue is tourists are not necessarily the most infectious people. If you think back to January or February, we had a ton of tourists coming through here. And most of the transmission that we saw in Oahu in March and April was from returning Hawaii residents who got sick on the mainland and then came back in and infected their homes. So we don't know if that's going to replicate itself this next time, but we have to remember that whatever rules we set up for tourists are also the rules that are going to be set up for Hawaii residents. Hawaii residents are a lot more likely to infect their family members when they come home. Tourists, a lot of them may stay in Waikiki. They may not have that many close interactions with locals. I would certainly worry about the tourism workers. And I worry about the tourism workers who then go home to their house and they're in a house that's a multi-generational family and somebody else in that family is a healthcare worker. And you can imagine the scenarios. So I'm concerned about it, but I don't know what the impact will be. The lieutenant governor might get lucky. He might have his 30 cases a day come through and it doesn't lead to a lot of local transmission and we get away with it. It's kind of a roll of the dice. We're not sure what's going to happen. What I would like to see is a more rational approach where we maintain the shield and we lower it very selectively and we go slow and we see how that works and we collect data on it. So, what I've been telling my friends on the county side is, the pre-travel test is absolutely a good idea. But ideally, we would have a post-arrival test of some kind. And there's different technologies out there. I know Dr. Otero was on your show. I saw one of his. He was talking about that. And I thought his little slideshow was pretty excellent, walking through that. So, if you do one of these rapid antigen tests, the sensitivity might not be quite as good. But they're really simple to do and they're cheap. And they're going to be available within a couple of months, we hope. So then what you could do is you could do it every 2 or 3 days. And get people out of quarantine at day 5, day 7, something like that. The other really important point is enforcing the quarantine. And this is my other beef with the state, is why aren't they enforcing the quarantine? All of this stuff only works if quarantine is real. Quarantine has to be real or it's all just pretend, right? Because, okay, let's say you think you might have gotten exposed, you're not sure. Or you think you might have some mild symptoms, but you're feeling fine. And you've already planned this vacation to Hawaii and spent thousands of dollars on your trip, right? You can show up and just say, I didn't take a test and I'm going to quarantine. And because there's 7,000 other people coming in, how the heck are they going to keep track of you? You scatter in 1,000 different directions, right? So there has to be a system in place to keep track of all those people. And what places that are serious about it have done is they've set up quarantine hotels. So you come in without your test, you get assigned a quarantine hotel. You know, it doesn't have to be one hotel; it could be multiple hotels that are bidding for that source of people, and then they pay cash. You know, until their tests come back negative and they're out of quarantine, right? So that would be a way to do that. But if you're going to have a way of getting out of quarantine, then you need to be able to enforce the quarantine, or the whole thing's a joke. And I don't see any real appetite to do that. And that's also interesting that there hasn't been an appetite to do that.
Well, there's definitely no appetite for that. And with 30 to 40 a day, remember that's a day. And with the, you know, the rate of, let's say with tourists, maybe they'll infect 2.5 people a day, each of them, or not a day, but they'll infect another 2.5 people. Those numbers rise pretty quickly. They rise pretty quickly. And again, without that effective quarantine, which this state has absolutely no desire to do that, it's going to be a problem. It's going to be a problem.
You know, Doc, here's been my fear, and now I'm going to hop back to the contact tracing, okay? And the reason why I'm saying it's for local people, it's very easy for us that if we were to get infected, because community-wise it's so small, we know everybody, right? So it's easy to say, well, I met Jonathan Dworkin. Yeah, I contacted him. I contacted Mel Raposo. You can tell the contact tracers all the contacts you made by name. It'll probably, that's the best way when you're dealing with a local person. But when you got someone from the mainland who knows nobody here, and you try to get, you know, who you came in contact with, they can't even pronounce some of the Hawaiian names. What makes you think they're going to tell you who they came in contact with? That's always been my fear factor, that how reputable is the information to get that net casted wide enough that you can bring it into a tight corridor so you keep it concealed and confined because look, in the beginning, we started with a few. How did it get into the 1,000 range? I mean, if you were a blind person, you would think had 1,000, you know, at one time was up to infected cases, 4,000, right? Over a period of time. You would think that, wow, 4,000 people came here and infected everybody, 4,000 of them. But it wasn't. It's just we never got down to the root cause. And so, you know, Mel and I being ex-cops, we always believed that if we follow the trail, sooner or later, it will circle around and come back where the origin was. There's got to be a critical path it's going to cross. But they never got to that point. They never got to that point throughout this entire time.
I think former cops would be good contact tracers. Maybe that was a mistake. You know,
that was two of the recommendations I think that we've made that over the months. We've made a bunch. Trust me, we've had the Senate COVID committee on our show several times. But number one, that was the first one. Hire all the retired cops as contact tracers. Get them all on board now and send them on their way. Teach them what you got to teach them as far as HIPAA or whatever you to cover your OCOLIs. But they're the best. No, you got to have a bachelor's degree. You got to have a medical background. I don't give a damn if you don't know how to interview or interrogate. That's not important. We just got to check a block. We just got to make sure we check a block. And then the second one, which ties right into this trial period of, we recommended that they do the inner island first. Rather than open Trans-Pacific, focus on the inner island quarantine. Right now we have an inner island quarantine that just got extended to October 31st, while the Trans-Pacific, they'll have an opportunity to take a test and get free of quarantine. So our suggestion was, do the inner island. Let's start small. Let's give the inner island residents an opportunity to travel the islands, visit family, do what they got to do, take a test before you leave, come back, and see how that works. Like a soft opening.
Yeah.
And if we start getting spikes, then we know, time out. Before we release the hounds off of those mainland planes, let's tweak it back up. No. They're going for it. Nothing gonna stop this train, Doc. And I'm worried, man. I'm worried for you guys, and I'm worried for the state.
Yeah, we saw contact tracing failure. That was my big frustration. Back in April. I mean, we talked to our patients. We said, has anybody contacted you from the DOH or your family? No. So that was going on. I think the quarantine wasn't being enforced. My buddy, David Dewolf, the director at KKV, they had these funerals. People were coming in to attend funerals, and technically everybody was supposed to be on quarantine. I don't even know if all of those got tagged as travel related. We don't really, we didn't have an effective contact tracing system at that point. We had a disintegrating mess, so we don't really know what happened, with those. But I'm not convinced that all of that explosion was purely local transmission. I think it might have been some introduced and some local, and we're probably not going to know anytime soon what happened with all that. But we need to do all those things. If you talk to Dewolf Miller, he'll tell you. He'll be like, he tells me, Don, do you have a fire department? You got a fire. Do you have firefighters? Do you have a fire department? That's the Department of Health. That's how he likes to say it. That's what dictates your pace of opening, right? You don't say, you know what, that fire up in Malibu, it's cool. We're going to have our convention down. We don't need a fire department, right? I mean, you got to make sure your fire guys are there and that they got the equipment and that they're trained and that they're up to the task, right? And then you talk about what you can do. So that's my take. And again, I'm biased. I'm an ID guy. When I took my boards, not allowing your town to get ransacked by the virus was the right answer, and I stand by it. That's how I was trained.
I'm biased too because I don't want to see people die. I don't want to see people get sick. I don't want to see people lose family members. I don't want to see people staying in a room, unable to see their families on their last moments on earth. I'm biased too, but it's there's got to be a balance, and the scales are tipped, I think, just in the wrong way. Now explain this to me, because you are an expert. I'm going to give you the scenario, and I want you to give me your prognosis or your diagnosis, okay, or the hell am I trying to say? I don't know, but here.
Halitosis.
Halitosis. So Kauai had two cases. Both travel related. But in today's newspaper, I think it was today's newspaper, the Department of Health, Dr. Behrman said, we don't have to worry because we know that this person wasn't infectious before they got on a plane. We know. How? Anyway, I'm just giving you the facts. Yeah. They fly to Hawaii. One was a returning resident, one was a visitor. We know that they went straight to quarantine and they complied. We know that. But they both tested positive. Okay, so we know that they're infectious free. And then we know that they go straight into quarantine.
So where do they get it?
Exactly. Spontaneous, sir. It's like spontaneous combustion. The fire in Malibu, poof, oops, what happened? Spontaneous combustion. Those crop circles in the mainland, what happened? Crop circles, the spacecraft came down and made the stuff. So
let me ask this. They tested positive while they were on quarantine. So they developed the symptoms during the quarantine and then were diagnosed. So they weren't walking around the mall or anything like that.
According to the article, according to Dr. Behrman, they were in compliance with quarantine. Yeah.
Okay. So this illustrates a couple of things. One is, let's assume they got a pre-travel test. We don't know the details of that, but let's assume that they got a pre-travel test.
Even if they got the pre-travel test, and they get on positive, they shouldn't be getting on the plane.
Right. But again, remember the state has confirmed that they were not infectious. So unless anyway, that 5-6 day window, whatever.
So this gives us that issue, right? Is right. Is it possible that the person was exposed but was not yet shedding virus? Then they would not technically be infectious, but they become infectious once they're here, right? So on the other hand, here's what I like about this story. I like it when people get infected while they're in quarantine, because to me, that's the benefit of the quarantine, right? That's why you have the quarantine. You want people, when they get infected, to be on quarantine when they're getting infected, not off quarantine wandering around. And actually, one of the statistics that we can track to look at the effectiveness of our system is what percentage of people who are testing positive are on quarantine when they tested positive. Because if they're on quarantine, if let's say that number is 50% or 60%, that means that the virus cops have done their job, right? They've gone out, They found the source of infection in the community. They've put those people on isolation. They've contact traced them. They've identified their close contacts. They've put those close contacts on quarantine. They've set up a shield to put incoming travelers on quarantine. And then you've got a certain number of people who test positive on quarantine. Okay, we can live with that. That means the system is catching those people. What we don't want is people converting to infectious while they're wandering around, right? So, and Kauai's done a pretty good job of that. Now, I can't make heads or tails of the not infectious and then got infectious here, other than to think that the person might have been exposed. And either they were infectious on that airplane, right? Or they developed their symptoms later, days later.
But here's the thing, when Mel first told me this thing, first thing that came to mind was this. They said that, number one, they didn't infect anybody on the plane, okay? But they went straight into quarantine, and they classified it as travel-related. So wait a minute. I can see you getting off the plane, and you come in contact with somebody at the airport. You're on the ground already. Yeah. It's not travel-related. Okay, yeah. That's mainly on community spread. Yeah. So when you put that in the paper, first thing I said is, "Wow, was there somebody going, woo?" You know, everybody come off the plane and you get one whammy. So it's when they release that kind of information, it makes you believe. Wait, first of all, the question I asked Mel was, number one, we're not conducting any testing right now. We're not, like how they did the surge testing, right? So this person had to present problems to get a test. So to go right into quarantine, but did they land and go straight to the hospital, get a test? Yep, you're positive, bingo, going to quarantine. Because on Kauai, we do have a quarantine facility. We put them in a quarantine facility. So to get there, you have to have taken a test. So now, and to be told that, oh, this person did not infect anyone else, good. Okay, I don't know how you invalidate that and then say it's travel related, and yet, wait, did the person get on the plane infected already? I mean, see, all of these kind of things is just popping up in our heads like, what the heck is this now? And see, when you do stuff like that, that's what makes people, like, you know, all those crazy rules, like in Honolulu had, you go to the beach, you got to go by yourself, leave the kid on the sand, that type of thing. When you start making crazy rules like that, that's why nobody wants to comply. You're actually feeding into them. You're creating more of a defiance than a compliance. That's what I say. And this is a prime example of what Mel just said.
Yeah. Well, it's been hard to get the rules. You know, having sat in on some of those discussions, there's always the, well, what about, and what about, and what about? So you try to set rules up that are going to work. And then there's the, what about this group or what about that group? And it's legitimately hard. I mean, the county governments, they've never had to manage a pandemic before, right? The multimodal response. You're talking to ID people, but you're also talking to emergency response people. You're talking to the police departments. You're talking to the economic interests. And I'm not surprised that hasn't gone smoothly. What surprises me is how many politicians seem to think they're going to be popular with uncontrolled virus transmission. I mean, I'm not a politician, but like, if I was, I wouldn't dare let this thing slip out of control, and I would just die on that hill. I'm an ID guy, so I'm biased, but that's the hill I would die on. I'd say, we're not going to have this here, and we'll do whatever we need to do. And there's so many of these guys that think they're going to be popular if there's just 100 cases, okay, or there's just 150. Oh no, we can handle it up to 250. We'll be fine. It doesn't make a lot of sense to me. And you cannot, it's not like a knob that you can turn. The virus is not something we have control over, right? It's a primordial beast that wants to get us. So we're not going to be able to modulate. Well, we'll have 75 this week, and then we're going to have 68 the next week, and then what we're going to do is then we're going to close the barber shops, and then we'll get it down to 64, right? But then we're going to open up the beaches, so then it'll be 72, but that'll be okay because the beach people will be happy. It doesn't work that way. It's exponential growth. The thing explodes, and by the time you're reacting to it, you're behind the curve already. So you gotta kind of stay on offense if you want to keep it under control. And the countries that have done that have had much more success, including in opening their economies. Because once it's really beat down, you can do a lot of things without worrying as much.
South Korea never shut down. South Korea never shut down. We had Minnie Ko. She's a consultant up in South Korea, and she's been on our show a few times. They wide open. They did not shut nothing down, but they had very strict quarantine. They had very strict contact tracing. They had very everything. Every component of this was done well. They had facilities where if you tested positive, and they run their labs 24/7. If your positive came at 2 in the morning, your ass was in a government car taken to a facility where you're going to wait there until you get tested again negative. And in some cases, some of these guys never cleared for over 30 days. That the virus was in them for over 30 days. Remarkable discussion we had. But there's all these examples and of places that did it and it worked. And we are choosing to go write our own book. And it's so funny you mentioned the politicians, because right before we brought you on, Charlie and I was talking about that. I said, these guys, you guys think being quiet about this, and I'm talking about the legislature and everybody else, you guys think about just being quiet and letting this thing pass is gonna get you reelected? Well, when the shit hits the fan, you won't. I'm telling you, people, they're not gonna appreciate this. And
Hey, Doc, you know what I noticed about this, and the reason why I'm laughing, because I'm a comedian between us two here, but I think of the Pink Panther. All these politicians, they're going dun dun dun, and they think nothing would happen, dun dun, and they're gonna see what rude awakening during election time. They're gonna get a couple dun duns, and then they go wonder what the hell happened. I said, hey, you should have made noise when you had the chance, you know.
Yeah.
And then, it's bringing people like you on that have that understanding. Like you said, you're an ID guy, right? Infectious disease. We know you live the reality and you've had the ability to control, but you know what it's like when it gets beyond your control, how bad it can get. And see, that's the question I want to ask you. If we do this one test, okay, we have no control of this. The administration made up their mind, they're going to do the one test. If in about a month this thing just gets so bad out of control and we can't even contact trace, how the hell are we going to fight it? I mean, do you foresee us going into another major lockdown, which will probably put a lot of businesses, they worry about economics. You don't have to worry anymore. They'll go under. What's your take on this?
Yeah, so I think there's a couple things there. There's the tourism reopening, and then there's also the reopening of Honolulu. And if you look at the numbers, even before we get to the tourism opening, we're not great. We're not down to single digits like we were back in May. We're 50 to 100 a day. The percent positivity is actually gone up a little bit in the last week. And now we're opening up things again, including some fairly high risk things. Now, I'm not a pro shutdown guy. I think as many things as we can safely have open, we should have open. But at the same time, some of the things that are going to be happening, like indoor dining and whatnot, we know are relatively high risk, right? So we've got that going on, and we've got a tourism opening going on, right? Here's the kicker. We may not have great data to guide us in a month. So let's say there's a spike of cases in a month. Is anyone going to share with us how many of those cases are related to incoming travelers? How many people tested positive through the CVS arrangement? How many people canceled their trips who tested positive? How many people threw out their results and got on the plane and quarantined, right? Are we going to have that kind of data available to us so that we can make an adjustment? Or are we just going to say, oh, you know what? We think this is all community transmission. Let's just keep going, right? And in order, and that's what I'm worried about, is that it's going to continue to be sort of a little bit shifty in terms of our understanding of the picture. In terms of our capacity to absorb it, one thing that I come out of the last 6 months with great faith in is the quality of the Queen's Hospital and some of the other hospitals to behave professionally through really, really difficult stuff. Those ICU guys at Queens, they're total warriors, and they can take a big hit and keep going, and they kept a lot of people alive. We don't have that level of service on some of the neighboring islands. We don't have tons of ICU doctors. I think there's one ICU doc on the Big Island, and I think in Waimea there's like 4 or 5 ICU beds. So we can't take a hit like that here. but Queens can take that hit at punch bowl on Honolulu, and they will function and they will do their job. They will show up, they will fight, and they will win most of those individual battles with the virus. Most of those people will get better. And I think when you don't have a defense up, that becomes the plan. The plan is let the hospital take the hit, and they'll fill up. And maybe if they fill up too much, we'll shut down again. But that's kind of bleak. That's not the situation I want to see us in. But I'm worried that that's the direction it might go, and it could go that way for a couple of reasons. One, it's tourism, but it's not necessarily tourism. I think we're perfectly capable of screwing it up all by ourselves if we don't do things well.
Well, I think Senator Donna Mercado Kim, when she was on our show, said, and I'll never forget this. She said, "Hope is not a strategy. We cannot hope our way out of this. I mean, we gotta do tangible things and stuff." Dr. Char says 50% of the positives that they're coming across aren't being cooperative with contact tracers as far as releasing their close contacts. That cannot happen. If we cannot get through 50% of our positive, hang it up, because we'll be on shutdown very shortly. If half of our positives we cannot contact trace, we're screwed. The other thing is today's article that we just talked about and laughed about and joked about. That's an example of what we're going to be given, the kind of information that we're going to be given to offset the concern for travel related virus. We're not going to get that information that you just described, which I think is vital. They're going to continue to try to push us to believe that it's not travel related. I don't know how you can discount the fact that someone was infectious or not on their flight over here. I just have no clue unless you tested them every freaking part of the way. And then when they landed, you tested them again. And I just don't see how they could have come to that conclusion. But it's a great conclusion if you want to convince people that travel is relatively safe. And that is my fear, Doc, is that they're gonna utilize the data in a way to justify their actions and not what the medical community needs to really do an honest assessment of what's going on. And I'm worried about that. I really am. The other big problem, Doc, and I know we're past the 8 o'clock, but Big Island may be a part of this too. If I'm in the mainland, if I'm in a hot zone, if I'm in Southern California, Arizona, wherever in Texas, and I want to go to Hawaii, I say, honey, let's go to Hawaii. The $242 round trip. Hotels are giving their rooms away. Which island, honey? Let's see. Honolulu? Shit, they got like 60, 70, 80 cases, 4 or 5 people die a day. Big Island, as long as you're not in a veterans care home, you're probably okay. But Hawaii, 0. Kauai is the safest island. Let's go to Kauai. That's what's going to happen, man. I tell you, people cannot underestimate when these guys are making their travel plans. They want to get out of a hot zone. They're going to come to the safest place they can find. And because Kauai did a great job, our mayor and his team did a great job, we're going to pay the price. We get 9 ICU beds here. 9 on the island. We cannot take a surge. We cannot take a load. But,
yep.
So.
Yeah, I agree. And I admire, I admire Kauai for the work it's done, and really, setting the standard. I don't know what the state of play is. I haven't heard the latest, but I know there was some talk of the mayors, individual mayors, implementing post-arrival testing, and I certainly hope something like that happens for Kauai, because of all the islands, I think Kauai has the best case for that. I mean, it's even more of a slam dunk for you than it is for Oahu. I think on Oahu, if the disease transmission gets to the point on Oahu where it's higher than the states that are sending Oahu tourists, then it's like, how much benefit are we going to get from this? You can start to legitimately question it. I think it's still lower than in most places. But Kauai, you're really at practically 0, which means you could get through this in better shape than 99% of the world. And, a mayor who delivers that outcome is a good mayor as far as that.
Maybe the next governor, who knows, man?
That's right. Yeah.
He took some bold action early on. He took some bold action, did the curfew. He shut everything down. I mean, he did very unpopular things in the beginning, but proof is in the pudding. And the quarantine the police and the National Guard here, they go check all the residences regularly. I mean, I got to say, man, not just because I live here, but I think we got the best island as far as keeping this thing down. But that can change in a day if we don't have a handle on the contact tracing, and man, this thing can get ugly real quick, and that's the fear. But I'm glad we got you on, Doc, because you know what, and I tell you, I was trying to find the actual comment. This was kind of early on in the show, and you were talking. Someone said that you give these people hope, Doc. You give them hope. That's what we do on this show. We try to educate and inform. But when they write a comment like that, we connected. You did. You connected with them. You gave them hope that there's people out there that are trying to do the right thing and trying to, get the right thing done. And that's the beauty of this whole thing. And I appreciate you coming on, man. I really do.
Oh, thank you. It's a pleasure. It's been a lot of fun, guys. Thanks for having me. And
yeah, any closing comments for you, Doc? For any, I mean, to all
no, I
the-
just I was thinking about what you just said, and I hope we have a happy ending to this, a relatively happy ending. One thing I learned early on in this is that we can't wait to be led. I think a lot of us, especially in medicine, I'm talking about my own tribe now. We don't want to be in meetings. We don't want to be on committees. We don't want to talk about policies. So we tend to, especially good doctors that like to connect with their patients and stuff. We tend to avoid all that stuff, right? And then we end up in a crisis, and we're like looking around, and we're like, wait a minute, who's in charge here? Who put that guy in charge? We got to step up a little bit as individuals, each and every one of us, and especially in medicine. This is what I've been telling my colleagues. We shouldn't be in a situation where we're being led by people who don't take into account what's going to happen to our nurse colleagues, or don't take into account the scientific reality of the problems we're dealing with. We got to step up a little bit. So I'll just end on that. We're not out of this yet, but I haven't given up.
Right on.
And neither have we. Charles?
Well, as always, I'd like to thank our guest tonight, Dr. Dworkin. Thank you so much for joining us. And because our show is all about educating, informing, and educating. And, like we tell the viewers out there, if you can use the information, fine. If you can't, then tune into the next show. Maybe there's something you can use there. To our viewers, you got a glimpse, a 1 hour glimpse. A lot of times we bring on individuals that you may have seen on the news, or you may have heard of them, and the news only shows a snippet, a 3 to 5 minute snapshot of what the person is. Tonight you got a full hour plus of this fine professional that believes in safety. I mean, that's what resonated through his entire time. He talked about the virus, what it can do, but how, if we can be safe around it, then we can coexist. We can coexist. But there's one danger that I'm gonna say it again. When you're dealing with this pandemic, on the medical side of it, there is no room for politicians to be involved with this thing. You cannot have politicians involved with trying to stop a virus. It's not going to work, because unless you have the medical knowledge to stop it, the politics, you're always going to, the rules in politics will always trump. It will always be the trump card to stop the good that the medical science wants to do. And that's when the politics have to stay out. So I hope you folks had a nice time tonight, viewers out there. Mel?
Thanks, Charlie. Thank you, Doc. It's a pleasure meeting you. We've met so many people virtually. I really cannot wait for that day when we can have, we're going to throw the Mel and Charlie Paina, which is going to be, Charlie going to pay for the whole thing. And we're going to eat, drink, and be merry. And we're just going to have fun. And with all of our viewers and all of the guests, and we're really looking forward to that day. It'll be on Kauai, though. You got to come here. And
I'd be happy to do that.
Just have some fun, man. It's been a long journey so far. We still got a long way to go. But, it's people like you, Doc, who are willing to step up. There's a lot of people going to see this, and I'm sure you'll hear about it. But we just, on behalf of our viewers, all the comments, I don't know if you have Facebook running, but if you don't, just go run on my page on Facebook and go read the comments later. All positive stuff. You brought them hope. They appreciate you standing up and speaking out, and so do we. So with that, thanks again. Get some rest, stay safe. Tomorrow night we have Dr. Jerome Kim, guys. You guys asked for it, you got it. International Vaccine Institute Director General, like the top dog, and he's gonna give us a whole bunch of ins. He's a great dude, great guy from Honolulu originally, made his ways in South Korea. Thursday we have Andrea Tupola. She's gonna talk about her experience not only with COVID, but with the unemployment division. That's gonna be cool. It's gonna be fun. And then Friday, Dr. Charlie, help me. Hang on.
Dr.
Friday is. Oops. Friday, sorry, Doc. Hey,
Okay.
how come I'm on Friday? I know we have somebody Friday. Oh, Dr. Steve Rogoff. Dr. Steve Rogoff from Hallelujah Clinic out in the North Shore, urgent care doctor. He's going to come on. So we got them all piled up for you guys this week. Tomorrow night, 7 o'clock. We love you guys. Take care. God bless. Stay safe. Doc.
Thanks, guys.
Stay safe, my man.